Hello, everyone. Dr. Lindner. We are going to continue this week in this short lecture on the lower extremity for osteology. So when we start the lower extremity, we're going to start with the pelvis. When we look at the pelvis, this is the right innominate bone, and this is the left innominate bone. And what's missing here in the middle, of course, is a bone, an important bone, that kind of sits right here, right? That sacrum. And the sacrum forms a joint, I'm going to exaggerate it, forms a joint here and forms a joint here. This is the sacrum, and this is the ilium. So the joint between the two is typically referred to as the SI joint or the sacroiliac joint, sacroiliac joint. The very top of the ilium is this right here, and this section here is called the iliac crest. That's like when you put your hands on your waist, but on the high up part, typically where a little bit above the belt line, that's called the iliac crest. It's an important landmark, and I'll show you why in a second. The pelvis is made up of 3 bones. 1 is called the ilium, 2 is called the ischium, and then 3 is called the pubic bone. So we have the pubic bone, which is this here. And then we have the ischium, which is this here. And then we have the entire ilium, which is this here. And when those 3 bones ankylose, which means ankylose means when they fuse, when the ilium and the ischium and the pubic bone kind of fuse, it creates this structure on the right called the acetabulum. The acetabulum is sometimes referred to as the acetabular fossa, the acetabular fossa. And it's best to see this if we rotate it laterally, because we want to be looking at it from the inside. It's going to look like a dish or a bowl. And it's a very, very deep depression that is designed to hold the head of the femur. It's designed to hold the head of the femur to make what we call the hip joint. And then remember, here in the center is cartilage called the pubic symphysis. This right here is a fibrocartilage, a very, very strong cartilage. This fibrocartilage would be called the pubic symphysis. Pubic symphysis. So when we look at the bone, now we're looking at this from the lateral view. So we're looking at the ilium. Right here is the acetabulum, right? That deep bowl. So that structure is here. What we're doing is we're taking this and we're rotating it sideways so we could see this. This part here is anterior, and then back here, this part is posterior. And then on the top here, that's still your iliac crest. Now, the reason why the iliac crest is an important landmark is because when you follow the iliac crest anteriorly, it takes you to this bump. That bump is called the anterior superior iliac spine. I abbreviate it as the ASIS. Stands for anterior superior iliac spine. Again, how do we locate it? We find the top of the iliac crest, we move anterior, and it takes us to that landmark, that bump. We can all feel it on yourselves. If you palpate it, it's the bump in front of the belt line. anterior superior iliac spine. If you're asked on an exam to label it, again, don't put the abbreviation. The abbreviation is just when I say ASIS, you know, it's the anterior superior iliac spine. Now, when we drop inferior to it, there's another bump right there. Now, if there's an anterior superior iliac spine, there's going to be an anterior inferior iliac spine. So we could abbreviate that anterior inferior iliac spine, the AIIS. Now, why are these important landmarks? These are very, very important landmarks because when we get to exam 3, when we look at muscles, these bumps are going to be attachment sites for muscles. And what's going to attach here to the ASIS is a muscle called the Sartorius muscle. The Sartorius muscle. It happens to be the longest muscle in the body, called the Sartorius. So the Sartorius happens to originate right there. And the AIIS right there, that's going to be an attachment site for a muscle called the Rectus Femoris. The Rectus Femoris. The Rectus Femoris happens to be one of the large quadricep muscles, one of the large, immense muscles in front of the thigh. So knowing these landmarks and understanding it isn't just important for the osteology exam. You have to retain this information because we're going to see it again when we cover muscles. Okay. Now, let's do the same concept on the back. So remember, when you follow the anterior, the iliac crest, and you follow it to the front, you get to the anterior superior iliac spine and the anterior inferior iliac spine. Same concept, if we follow it to the back, it takes us to the posterior superior iliac spine. We call that the PSIS. That's right here, that large bump right there. And if we drop inferior to that, there's another bump here called the PIIS, the posterior inferior iliac spine. So this is a strategy that I teach to try and help my students kind of study and figure out the landmarks in a very organized manner, right? Start somewhere, and where does that lead you? So start at the iliac crest, always a good place to start, and then go, all right, if I go forward, anterior superior iliac spine. If I go back, posterior superior iliac spine. If I go back and down, posterior inferior iliac spine. If I go front and down, anterior inferior iliac spine. Okay. Don't forget the acetabulum or the acetabular fossa. Now, this is the looking at the ilium from the outside, right, from the lateral view. When we look at it from this side, the inside, if we were standing on the other side of this individual, we'd be seeing this view. And right here is a depression called the iliac fossa. Remember, a fossa is a smooth depression. There's an iliac fossa. Again, what's the significance of this iliac fossa? There's a muscle that we're going to be learning called the iliacus. The iliacus. It is a large, powerful hip flexor. It's a powerful hip flexor. So it's going to originate on the iliac fossa, this iliacus muscle. Okay. All right, so far so good. There's a hole right here. This large hole is called the obturator foramen. Obturator foramen. Again, this hole here, I'm marking an X in it. This hole here, I'm marking an X in it. That's called the obturator foramen. Okay, let me clear these out. Let me erase these so I could draw something else here. Let's see if I can erase it all. Okay. Now, another structure I want to show you. Right here, this little bump right there, we could see it on the right-hand side right here. That's called the ischial spine. Ischial spine. Ischial spine. Now, the importance of the ischial spine is that it's going to separate, let's make this red, it's going to separate this notch from this notch. Again, it's going to separate this notch from this notch. There's two notches separated by the ischial spine. Not the ischial tuberosity, the ischial spine. And the ischial spine is going to separate the greater sciatic notch. It'll separate the greater sciatic notch from the lesser sciatic notch. The lesser sciatic notch. Now, what do you think is going to travel through the greater sciatic notch and the lesser sciatic notch? There's going to be a nerve that's going to travel right between the greater and lesser sciatic notches, and that's going to be called the sciatic nerve. And that's why pelvic alignment is so very, very important, because if that pelvis tilts or misaligns, whether it's tilting anteriorly, whether it's tilting posteriorly, or even laterally, as if one hip is higher than the other, it's enough to change the orientation of the ischial spine and the greater and lesser sciatic notch, where that can pinch the sciatic nerve. Okay, let's look at this. Now we're looking at it from the back, and there's a few things I can show you here. We're looking at it from the posterior. So let's put posterior here. And here's the iliac crest. Here's the iliac crest. Now, what happens if I follow it to the back? What is the name of that bump right there? Well, that is going to be called the posterior superior iliac spine. And if I continue down and I drop down to there, right? Here's the posterior superior iliac spine. And right there, the bottom one is the posterior inferior iliac spine. Okay. We can see right here is L5 vertebrae. And we can see right there is the joint or the junction between the superior articulating facet of L5 and the inferior articulating facet of L4. And then here's the spinous process of L5. Here's the obturator foramen. And right here on the bottom, the part that you sit on, that's called the ischial tuberosity. Ischial tuberosity. It's the roughened part of the ischium. So it's the ischial tuberosity. What's the significance of the ischial tuberosity? Well, the ischial tuberosity is going to be where your hamstrings, I'll call them the hams, where your hamstrings originate. They attach right there to the ischial tuberosity. And then here from the back is your sacroiliac joint, the SI joint, sacroiliac joint, the sacroiliac joint. Okay, so now when we isolate, we just look at a few of the landmarks here. we could see, just to review, repetition works. That's the acetabulum, or this is also known as the acetabular fossa. Here is the obturator foramen. That's the hole. This is the pubic bone. This is the ilium. This is the ischium, but this roughened part right there is called the ischial tuberosity, and that's where your hamstrings originate. Ischial tuberosity. Here's your iliac crest. You follow it to the front, right there, ASIS, AIIS. Let's follow the iliac crest to the back, PSIS, PIIS. This right here, ischial spine, my bad. Let's call it the ischial spine. Not to be confused with ischial tuberosity. This ischial spine is this point, and again, it's going to separate the greater sciatic notch from the lesser sciatic notch. Looking at it from the front, you could see the sacroiliac joint this way from the front. Here and here, that's the SI joint, sacroiliac joint. Here's your L5 vertebrae. This is the L5 S1 disc right here. Here's your pubic symphysis. That's the fibrocartilage right in the center. And here's the pubic arch right here, right? If you just draw a line following this, that is a male pelvis. If it was female, it would be much wider like this. Okay. Here's the iliac crest, anterior superior iliac spine, anterior inferior iliac spine, acetabulum. These are called pubic tubercles. Those two bumps right there, pubic tubercles, pubic tubercles. And then here's your obturator foramen, obturator foramen. This smooth depression right here on the anterior, that's called the iliac fossa, the iliac fossa. Remember, it is the origin for the iliacus muscle. Okay, moving down, let's look at the femur. When we look at the femur, we have the femoral head, right, which is this. Then we have the femoral neck, which is wrapping around here. And if you think back to the arm, to the humerus, there was a greater and lesser tubercle. When we look at the femur, the longest bone in the body, there's a greater and lesser trochanter, not tubercle, but trochanter. So this is the greater trochanter here and here. And more medial is the lesser trochanter. And again, these are going to be very important attachment sites for muscles, okay? Your iliopsoas muscle is going to insert here, a muscle called the iliopsoas is going to insert on the lesser trochanter. And your gluteus maximus, medius, minimus, they're going to insert there on the greater trochanter. So the greater and lesser trochanter, again, serves as attachment sites for very important muscles of the hip. Here's the shaft of the femur. Again, the femur is the longest bone in the body. Notice the angle of it, right? So it goes from lateral to medial when we're looking at it. It kind of goes on this diagonal. Right here on the anterior side is the patellar surface. The patellar surface is really the surface for the kneecap, for the patella. A lot of improper tracking issues of the patella occur if this is abnormally shaped. If the patella surface is going through some degenerative changes, it's kind of painful for people to flex and extend their leg. When we look distally, there's going to be a medial epicondyle. Remember, epi is above, so the medial epicondyle is above the medial condyle. On the lateral side, lateral condyle, and above it, the lateral epicondyle. Epis are always above. Okay. On the posterior, so let's put an A here for anterior. That's your anterior. When we look at it from the posterior side, on the posterior, there's this sharp line. It's a pretty sharp ridge back here, and it's called the linea aspera. The linea aspera. And at the distal portion, right back here, there's a popliteal surface. Popliteal surface. Now, these rounded condyles, both the lateral and the medial condyles, are going to articulate with the bone that will be inferior to it, called the tibia. And these are round, right? These are kind of like rounded contour, but the top of the tibia is pretty flat. So when you have a round surface sitting on top of a flat surface, it kind of makes for an unstable joint. And the knee joint is the largest joint in the body, and it is very, very unstable, bony-wise. And because it's so unstable, bony-wise, the body creates a lot of soft tissue structures to help stabilize it, lots of ligaments to stabilize it. So here's the kneecap, that's the patella, and the top of it is called the base, and the bottom is called the apex, right? The base is not always the bottom, it's just the widest part. So the base is on the top. Some textbooks call it the superior pole, and they call the apex of the patella the inferior pole. Okay, so base and apex of the patella, that's your kneecap. As we move down and we look at the leg, so right here, this bone is the tibia. And on the top, right, this is pretty flat. This is where the rounded condyles, that's where the rounded condyles are going to be of the femur, the femoral condyles. So there's got to be lots of soft tissue structures there to help strengthen and to help stabilize the knee due to very, very poor bony support. So some of those ligaments, they're called the meniscus. You have the meniscus, and there's a medial and lateral meniscus. Many people end up having orthoscopic surgery of the knee because they have a torn meniscus or a degenerated meniscus. And it's really, really strong cartilage. It's fibrocartilage, much like the discs in the spine and the pubic symphysis. But the meniscus, especially the medial meniscus, is commonly torn when you're doing some sort of running. You're running in one direction and then you stop short and then you turn your body, like in tennis. You run, the foot's planted, you turn. In basketball, you're running, you stop, you pivot. Anything, soccer, you're running and then you stop short and your feet are planted and you turn. Whenever there's that rotational component, typically the medial meniscus, people often hear a popping sound with that, with the medial meniscus. There's also the medial and lateral collateral ligament. It's called the medial and lateral collateral ligament. The C is for collateral. Those are going to stabilize the inside and outside of the knee. So the lateral coligament, let me see if I can change the color here. We'll make it blue. So the medial collateral would go this way, and then the lateral collateral ligament would go this way, right? It's going from, the medial goes from the tibia to the femur, and then the lateral collateral ligament would go from the fibula up to the tibia. Remember, ligaments go from bone to bone. Okay. This structure right here, sorry, there's another ligament in the middle. They make an X, and they're called cruciate ligaments. Cruciate. C-R-U-C-I-A-T. Cruciate ligaments. And cruciate comes from the word like crucify, like cross, the crucify. So it actually makes a crisscross in the middle of the knee joint. There's an anterior cruciate ligament, and then there's a posterior cruciate ligament. And these are the ligaments that are designed to prevent the tibia from gliding anteriorly or posteriorly in relationship to the femur. So the cruciate ligaments are designed to prevent what we call anterior and posterior translation of the tibia in relationship to the femur. So how do these get damaged? You could be sitting in the front seat of a car, your knee is close to the dashboard, you get into a car accident, and the dashboard pushes back on your tibia, driving the tibia back. You damage the posterior cruciate ligament. A football player is running, they're running, and someone is trying to tackle them from behind. So they jump and they tackle them, but they grab them from the back of the leg and they drive the back of the leg forward. Now the tibia moves forward in relationship to the femur, and you tear the anterior cruciate ligament. So the cruciates are designed to prevent that anterior and posterior translation or gliding movement of the tibia in relationship to the femur. So we have three sets of ligaments. We have the meniscus, which is a medial and lateral meniscus. Then we have a medial and lateral cruciate, medial and lateral collateral ligaments, which are these. And then we have the anterior and posterior cruciate to try and make up for some of the bony or osseous instability between the femur and the tibia. Okay, when we go inferior from that top of the tibia where the condyles are, right? This whole section from like here to here, that's medial condyle, and this is the lateral tibial condyle. Right here is a bump. We all have this bump in front of the tibia called the tibial tuberosity or tibial tubercle. And you can all feel it on the top part of your tibia. Some are extremely prominent, especially if you played a lot of sports when you were younger, like soccer, hockey, basketball, anything that overused your leg muscles, your thigh muscles, called your quadriceps. The quadriceps attach to the tibial tuberosity. And because the quads, four immense large muscles, insert on the tibial tuberosity, every time your leg extends, it's contracting and pulling on that bone. And as the bones are developing when you're younger, that bone can start to avulse away and becomes more prominent and distinct. So that's the tibial tuberosity, and it happens to be in the same line as, let me see if I can erase this again for you. The tibial tuberosity is in the same horizontal alignment as this, which is the head of the fibula. So this is called the head of the fibula. It's in the same horizontal line as the tibial tuberosity. That's called the head of the fibula. Here, where the fibula and the tibia meet, it's just called the superior tibiofibular joint, and down at the bottom is an inferior tibiofibular joint. When you go all the way down to the ankle, this large bump right there is called a medial malleolus. And if there's a medial malleolus, there's going to have to be a lateral malleolus, which is there on the fibular side. Okay, but the fibula is the lateral bone. That's why this is the lateral malleolus. Lateral malleolus. And the tibia is the medial bone, so it's the medial malleolus. So medial malleolus down at the bottom, medial tibial condyle up at the top. Same picture. Now we look again, remember here on the tibia right there, that was the tibial tuberosity. And in the same horizontal plane, it takes us to the head of the fibula. This is the shaft of the fibula. All the way down at the bottom, lateral malleolus of the fibula. Remember, medial malleolus is on the inside. That's associated with the tibia. This is the fibula. Again, on the top is the superior tibiofibular joint, and on the bottom, the inferior tibiofibular joint. It's just where the two meet. There's no real major motion or movement that takes place there. It's just where the two bones join. And now to finish up, we'll look at the ankle joint. Down at the bottom, we're looking at a superior view here. When we look at the superior view, the most superior bone is called the talus. So the talus, this bone here, is going to articulate perfectly with this. Right here is where the talus, I'll put a T there, the talus is going to be part of the ankle joint where the lateral malleolus and the medial malleolus come together. It's going to come together like a monkey wrench and squeeze and hold the talus right there, so that the talus, the ankle, can dorsiflex and plantar flex. So that's the most superior and highest tarsal bone. There are 7 tarsal bones, not to be confused with the 8 carpal bones. The heel is the calcaneus. That's the heel. Then we have the navicular bone. Here, the navicular is going to articulate with the medial, the intermediate, and the lateral cuneiform. So there's 3 cuneiforms: the medial, the lateral, and the intermediate, which is between. Sometimes they'll call this the cuneiform 1, cuneiform 2, cuneiform 3. Makes no difference. It is correct. Whether you want to refer to it as the medial cuneiform or cuneiform 1, the intermediate cuneiform or cuneiform 2, or the lateral cuneiform or cuneiform 3. They'll all be correct. Lateral to the 3rd cuneiform is the cuboid. That's the cuboid. The cuboid is going to articulate with the 4th and the 5th metatarsal, whereas the cuneiforms have their own metatarsal, right? So you have metatarsal 1 articulating with the medial cuneiform, metatarsal 2 with the intermediate cuneiform, and then metatarsal 3 with the lateral cuneiform. Then the cuboid articulates with the 4th and 5th. Okay, so you have the 7 tarsals, then we have the 5 metatarsals, metatarsal 1, 2, 3, 4, 5. And then much like the hand has phalanges, right? We call them digits or phalanges. And there is a proximal, a middle, and a distal phalange of digits 2, 3, 4, and 5, right? There is a proximal, a middle, and a distal phalange of digits 2, 3, 4, and 5. The great toe, digit number 1, has a first metatarsal, and then it has a proximal and a distal phalange. It does not have a middle phalange like all the rest have. Okay. When we look at it from the side view, this is a lateral view of the right foot. Here is the talus, that is the most superior, highest up bone. So this is where the lateral malleolus and medial malleolus is going to clasp the talus. We can see it here, the lateral malleolus and the medial malleolus. We have the heel, which is known as the calcaneus. And there is soft tissue structures that go this way, right? It's going to go from the heel to the toes. They call it the plantar fascia. And sometimes when the plantar fascia is being overused, you get something called plantar fasciitis. Happens in a lot of runners. When the plantar fascia has really good tone, it's going to create a really nice arc. When the plantar fascia is weak and overstretched, that's when you get a flat foot. So we call flat feet pes planus, and we call high arches pes cavus. Pes cavus would be high arches. Pes planus is flat feet, and about 7 out of 10 people do have flat feet. Okay, from the lateral view, we could still see a bit of the navicular. We could see the cuneiform bones, but we can only see, it looks like, the intermediate and the lateral, right? Because this is a lateral view. We can't see the medial cuneiform. You'd have to be on that side to see it. But you can see the intermediate and lateral, also known as the 2nd and 3rd cuneiform. And then right here is the cuboid. And then you have the 5th, 4th, 3rd, 2nd, and your 1st metatarsal. Then you have your phalanges. And remember, there's a proximal, a middle, and a distal phalange of toes 2, 3, 4, and 5, but the great toe only has a proximal phalange and a distal phalange. Let's not forget that, okay? From the medial view, now we're looking at the foot from the inside. Really nice, you can see the arch. Remember, there's soft tissue structures that run this way, that plantar fascia. When it's really, really tight, sometimes the calcaneus has a little bony point that grows. It's called a heel spur. And then every time the person takes a step and they land on the heel right there, it becomes very painful because the bone spur, this heel spur, is jabbing a lot of the musculature. So what we do for that is we make specific orthotics for patients, and they have a heel spur correction, which is like a little divot that we build into the orthotic like this, so that when the person goes and heel strike, when they're walking, this spur hits this nice cushiony depression. So we can see the talus on top. We could see the calcaneus, the heel, on the bottom. This is where the Achilles tendon attaches, right? The Achilles tendon attaches back here. to plantar flex the foot. We could see the navicular. And now, because we're on the inside, we could see the medial cuneiform, or cuneiform number 1. Then you have your first metatarsal, your proximal phalange, and distal phalange of the hallux, the great toe. Toes 2 to 5 have a proximal, a middle, and a distal phalange. Okay.